University of Bern, Switzerland. Dr. Rabe completed his medical training in the Medical Academy in Dresden and did his neurosurgical training at Klinikum Chemnitz in Germany. He also completed a clinical observership at the Neurosurgical Institute in Phoenix, Arizona. Dr. Rabe specialized in microsurgery of brain tumors and intracranial aneurysms, as well as advanced image guidance and monitoring of intracranial surgeries. He is involved in medical education, research on imaging and navigation technology, such as the development of the Zeiss microscope into neurosurgery, and he published widely in peer-reviewed articles on cerebrovascular disorders. We're excited for his talk today on changes in the management of unruptured intracranial aneurysm. Dr. Rabe, thank you for joining us today, and you're welcome to share your screen.
Yeah, so thanks a lot. Thank you for letting me be here with you. So it's truly an honor and a pleasure. And I would like to give you a wrap up and some information about the larger topic of unruptured aneurysms. And of course, very important for us is the management of these aneurysms. And there's still a lot of unclear situations where we would need some information, numbers, and so on. So I'd like to go to this topic now. This is the culprit. I mean, we have seen many of these videos, small, innocent, but still you see blood circulating inside, and this is the benign stage, and that's the stage, of course, that we want to prevent the rupture. But I will come to this topic that it's not only the rupture that we want to prevent what we are doing. So starting, I'd like to give some numbers, although I know that for many of you it's quite early in the morning, but numbers are important for reasoning and for decision making, and we have to go through some of them. Prevalence of unruptured intracranial aneurysm is estimated to be 3% at least in a big systematic review and meta-analysis. I changed this number a little bit to 1 to 3%, because if we look into the sources for this meta-analysis that included sometimes older patients, sometimes autopsy studies, I'm not quite sure if it's really 3%, but that's the number that's always quoted. A little bit in contradiction to this is how we often find aneurysms on the MRI. There's one landmark study from the Netherlands. They quote 1.8%, and we take this as a confirmation of the number that we have from the prevalence from the autopsy studies and the angiography studies and so on that I showed before. But if we take all the publications and the recent meta-analysis from 2022, there's only 1.3, that's the average, so 3 cases per 1,000 scans, and then up to 1.8%. So it's a little bit blurred still, the picture. So I wouldn't, encourage you to use the 3% for all of the estimations that we have. On the contrary, that's just the innocent aneurysm. What about the rupture of the aneurysm? That's the number that we have from Switzerland. It was going down over the last 10 or 20 years, the same what we saw in even in Finland, where we had for many years, we saw more SAH, and now they have also come down to numbers that are seen all over Europe and at least the Western world. And in Switzerland, we have about between 4 and 5 cases per 100,000. And that's already a big discrepancies if you think there are 1 to 3,000 cases per 100,000 inhabitants, and then only maybe, with all the patients maybe dying on the spot. So 5 per 100,000, that's the incidence of the SAH. What's the outcome? of the rupture. I think this is an important topic because sometimes we compare risk of rupture with it's the same like death in our thinking sometimes with the intervention complication. This is also a topic I will come to. And the data that we have obtained from recent years show us that the outcome it's bad, of course, but still there might be some numbers even that you have 50% of patients reaching a MRS from 0 to 2 after rupture of the aneurysm, and that's kind of a high number. I'm still surprised that we have so many good outcomes after rupture, but that's a number we have to keep in our mind. So, and now we have to put together these numbers for the decision making. One of the important questions is, do we really want to prevent SAH when we treat unruptured aneurysms? And of course, if I ask like this, it's no, it's not to prevent the rupture. It's prevent the poor outcome, and let's turn it around. The goal is to save the highest number of quality adjusted life years. And I stress this topic to maintain quality adjusted life years, because I will also come to this later on. We have 3 factors, of course, risk of rupture, of course, remaining life in good quality. It's of course determining how many quality adjusted life years still the patient have. And then of course we have the risk of severe complications. And that is the formula that we use in our clinical decision making. And it has to be based on some numbers. And this is the everyday situation when we see a patient with an unruptured aneurysm to make our decision. So now to the risk of rupture. I think it's pretty much clear. No matter if this is 1%, 2, 3, whatever. I think larger aneurysm, and I would say larger in terms of making a treatment decision. It starts around 10 millimeter, and we can, having the ISUIA data in mind, we can even say larger than 7 to 10 millimeter. There's some zone. I think that's quite, or it's easier to make a decision with these aneurysm. But much more often we see the other patients with an aneurysm that is less than 7 millimeter. And no matter where we have the location of the aneurysm, it's still a category that needs more information about the aneurysm and the patient. In the old days, before the ISUIA study was published, the retrospective and the prospective arm, we had the belief that every unruptured aneurysm has a risk of 1% per year. And then the ISUIA came, including 700 patients, followed untreated, and roughly 1,000 patients had additional unruptured aneurysm, which means they had previous SAH. So in this study, 615 patients had incidental aneurysm, follow-up time 4 years, making a lot of patient years to study these aneurysms. And when these results were published, I remember that we all said this can't be true. I mean, it can't be true that a small aneurysm less than 7 millimeter, where the patient had no SAH and the anterior circulation is 0. When we see in our daily practice in the emergency room so many patients with ruptured aneurysms of 5-6 millimeters. So, of course, a lot of, interest sparked, and could be true that this is 0% or not. We did a study comparing the size and the width, the height and the width of ruptured and unruptured, and there is not much difference. You cannot do any judgment from these curves. I think they are really overlapping. And then, of course, there's a discussion, and I think we need to have these numbers, and we need to know how to interpret ISUIA. And we think we have a lot of new information, which is valuable, but also a methodological flaw. So nowadays, we wouldn't accept that we post hoc assign the aneurysm location. So if we see, okay, we can now take out PCOM and put it to the posterior circulation, and then we have a 0, that's not the way we should do it now. You have to define this before. The same is about the size categories. You have to define the size categories for. You cannot just make it fitting to the numbers that you see. And then the subgroups are quite small, only 4 years follow-up for only 11 ACOM aneurysms. 1/3 of patients were treated. We don't know why. Probably they grew or changed configuration. This is not reported. And 11% died within 4 years following the studies. We don't know why they died. So there is a lot of methodological problem inside, and still the major message that ICUIA delivered was, and that's really the game changer, they have a much lower risk of rupture compared to what we believed before. I think we need to have this in mind, and we need to know how. How could we explain this kind of discrepancy between having, an ruptured one in the emergency room, and we have a patient, with a 5 millimeter and SAH. On the other hand, if we observe an unruptured one, the likelihood that this will rupture is very low. And I think there's only one really good hypothesis, and this is that the aneurysms, they grow, and the formation of the aneurysm is quite fast. It has to be fast, because otherwise the period would be more observable when you see an unruptured. You would see some more ruptures after observing an unruptured before. So probably within days or weeks, there is an unstable aneurysm with a very high risk of rupture. And then if the aneurysm survives the formation phase, there's probably a post-formation stability when the aneurysm has quite a low rupture risk, which is only significantly changed if the aneurysm grows. So this concept considers all the factors inside, or many factors inside, and I think it's still the best to explain this large discrepancy between the sizes, the small ones we see in the emergency room. How fast can it be? We had one case where we saw the aneurysm formation, within a few weeks, and it could be fast, and it's very difficult to really capture this moment. So, but I think from the hypothesis and also from occasional observations, we could believe that we have some support for this hypothesis. Then afterwards, after the ICUIA was published, of course, many groups went back and went into this the data that they have, and one of the data many groups they had studies running or looking back, and unfortunately, still ICUIA remains the only large study for countries without, Finland and Japan. At that time, Finland still had a different problem about a different rupture rate. So still, we couldn't find an answer, maybe for Europe and for the United States. And then we have this range of still numbers 0.1 to 1%, depending on other factors. So everybody knows the different scales of, phases or whatever, the Finnish score and so on, and all of them rely on different factors. We can go through them, but that's kind of, I think, also lost of time. The only scale that has established was the phases score now. We use the phases score, which takes into account the population, patient hypertension, age, size of aneurysm, early SAH from another aneurysm in sight of the aneurysm. But we are also cautious and take other factors into account, like the configuration of the aneurysm and so on. Because phases was built from 6 studies, and ICUIA is one of them. It's the largest one that is including, these numbers from the Western world. It's the green. The largest ever is the UCAS, and sort of the Japanese. It's biased towards Japanese patients. The phases score, and still we have to keep in mind with which patient population we make our scores. And then there are also discrepancies between ISUA and phases. If you use, for instance, 7 millimeter aneurysm, no previous SAH, in the anterior circulation, you have ISUA of 0, but phases 0.1 to 0.5. The anterior cerebral artery has no risk factor in ISUA, but 4 points a major risk factor in phases. Previous SAH is a major risk factor in ISUA, but not in phases. And then an 8 millimeter PCOM could end up in completely different risk categories. So still, but we have to use some numbers, and I think taking into account the 0 from ISUA, I'm doing a little bit more having a trust in the phases. All right, so now let's put one of these, I call this, it's a classical uncertainty case. It's a patient less than 70 years old. Maybe he has hypertension, maybe he has even had an SAH, which would, for many of us, trigger even higher now our decision making. But let's use the phases score, 7 millimeter or less. And then if you use this phases score and we break it down, phases is a score for 5 years. If we break it down to 1 year, we have very low risk rupture rates. For ICA, it's 0.1% per year. For MCA, it's 0.15% per year. And that's very low. And still we treat many of these aneurysms. If we now go to a range of 7 to 10 millimeter, which is, yes, it's larger, still in the range where we have in the ICA and MCA risk rupture 0.2, 0.35% per year. It's still quite low, but considering the age of the patient and so on, so we now change very often towards our decision making towards treatment. But still, it's not quite clear if we are on the right side. But the decision making is influenced, by many other factors. So the risk of rupture of a small aneurysm of the anterior circulation is very low. And I'm not talking about the basilar artery aneurysm and the pica aneurysm. So I'm just talking about the majority. What happens if we see a growth of the aneurysm, like in this case? And yes, it's quite often. We quite often see growth. And in our database, we have a 20% growth rate after 5 years. And that's pretty much the same that we see on the big numbers. We can judge the risk of growth of an aneurysm. It's basically the same as the phases score. It's also depending on the size, on the location, on the population, on the age. So I think it doesn't really need even a separate score for it. But the more important question is, what does it mean for the management? We don't know how regularly the aneurysm grows. So if it would be continuous, we could wait, basically. If it's regular, discontinuous, we could still schedule imaging. But if it would be irregular discontinuously, we would be very difficult, in making a follow-up in these patients if we knew it could grow a lot within a very short time, and then the risk of rupture would increase considerably. The risk after growth, in my mind, I had always the 10% per year from Japanese studies. And then there was this studies from the Netherlands investigating different factors for the risk of rupture after growth, the size, for instance, shape, and site. So it's the SSS score. But for me, it's not important to know it's 2% for this and 3 and 5, whatever. I think everything that starts at 2% per year is triggering treatment in most cases. So the message from this study is not that you should know how many S is coming or inside. It's just that, as soon as an aneurysm grows and you see it grow, and that has not been addressed correctly, but I'm sure it's exactly the same. As soon as you see a major change in configuration, I think the trigger for treatment is then there. There's another factor which influences the risk of rupture in my mind, which is a little bit less elaborated on, but we see this indirectly when we just look only at the size of the aneurysm. So if we would only look at the size of the aneurysm, we would have more ruptures that, the internal carotid artery, the proximal ICA still has larger sizes than maybe a distal A2, A3 aneurysm. But still the numbers are quite low for the ICA. And we do have some information from the ISUIA study that the aspect ratio, that's the Japanese and other studies, but also the size to vessel ratio influences also the risk of rupture, which means the more distal you go, the more likely is that also a smaller size may rupture. So the relating or bringing together the size of the vessel and the size of the aneurysm makes somehow sense. You have significantly more ruptured aneurysms in the smaller size in the distal periphery, and I think we should also take this into account. So the smaller distal unruptured aneurysm may have similar risk or a higher risk compared to the same size in a more proximal aneurysm. Okay, now the next piece for making decision making, which is the complication rate. Of course, this is one of the factors if we want to go for the highest number of quality adjusted life years. And there is, of course, no such thing like a complication rate of unruptured intracranial aneurysm. You have the good, the bad, and the ugly. And we have the good aneurysm, which is the small size, the small neck, non-complex, superficial anterior circulation. This is now a clipping image. It could also apply to endovascular treatment, of course. Then you have the treacherous, the bad ones. These are the large, wide neck, calcified thrombosis. You know exactly that's going to be a bad aneurysm. And then you have the treacherous, the underestimated aneurysms that you think you could treat easily. But then, for instance, for clipping, this is calcified. You don't get a clip over here. You have to fiddle around and put clips otherwise. But still it's blocking the calcified base, slowly mounting into a disaster if you don't stop, if you don't retreat or have a good strategy. So, but there is no single complication for the treatment, as there is no rupture rate for a single aneurysm. And if we are talking about clipping and coiling and the complication rate, I would say we can say there's a good aneurysm and there are bad aneurysms. And in the large aneurysms, the giants that have, of course, the highest risk of rupture, they also have the highest risk of complication. So we just can't give ranges. And I believe they are not really different between clipping and coiling. And when we see the statistics of people discharged at a nursing home and whatever, and we compare clipping and coiling, we are compared, of course, apples and oranges. So because there is a selection process going on, how to treat this patient and this patient. So the only thing that could be different is, I think, the risk of death could be, although very low, could be a little bit higher in coiling than in clipping, because you have more abilities to really manage a disaster when you are intraoperatively for the good ones. I'm not only talking about the good ones, the small aneurysms. So decision-making has overcome the stage that we had in the 2000 years when the ISAT study came out, and then there was a fight between the surgeon and endovascular, and we are better, and this is better, and we do this study, and that was not right. So I think now the resident is pretty much clear that everybody sits together. We put expertise results together. We know the results from each other. We have seen what the guy next to us is doing or in our own department, and then we judge individually what is the risk of the patient for the treatment. And if you put it together, you can easily put, for the neurosurgeon, for the neuroradiologist, let's say 5 stages of different difficulties and success rates. So the difficulty, which means the complication rate, the success rate, which means the complete occlusion rate, or maybe the near complete occlusion rate. You can put it together. And if you have an easy doing for the neurosurgeon with complete clipping, and you have a difficult aneurysm for the neurologist, maybe some MCA aneurysms, the surgeon is doing it. And for many of these aneurysms, we can have a different level of difficulty and success likelihood, and we can judge the best approach for the patient doing like this. Okay, now what would be the best if we say, okay, that's different, but what if we have an aneurysm that could be treated with both with the same likelihood, and both say, okay, that's for me good, for you good. So what is the better method? So, and how should we study this? I mean, prospective studies of treated, selection bias. Discharge database, as I said, selection bias. You don't know. You have to have either a very strong registry, like in some spinal studies even, where you have this observed, the patient randomizes himself. If he randomizes objectively, they can say, no, I want to have this or this treatment, or you really randomize. Systematic review and meta-analysis, I'm not a believer in this because there's so much bias into it. And then, of course, it comes to the randomized trial. And thanks to Tim Dossert and his group, we have now a study. I think that's the best that we have, a pragmatic randomized trial comparing surgery and endovascular treatment of unruptured aneurysms. For those of you not being aware of it, I'm quickly summarizing it. It's about unruptured aneurysms. The size is from 3 to 25 millimeters, so including almost giant or giant aneurysms. These aneurysms had to be judged treatable both ways by the participating physicians, and of course, blinding for treatment is not possible. The primary endpoint, and that is, of course, the major criticism, is the failure of occlusion. And just by reading this, you know that surgery has the advantage of having a higher rate of initial and in the first 1 or 2 years, higher rate of occlusion. And it's not comparable to hemorrhage from the aneurysm. And even a secular residual aneurysm after 1 year, if it doesn't translate into rupture, is not an endpoint that could be compared to hemorrhage. So the endpoint is somehow biased. So I will not really go for the endpoint, but for the primary, but the secondary endpoint I think is more important, and that's the deficit after treatment. It's the Rankine score after treatment. So, and that is the summary of the complication rate. And what we see is, in terms of size, we still have 18%, or about 20% of larger aneurysm included in this study, which in my mind then limits a little bit the value of complication assessment, because we are specifically looking on interested for the large group of small aneurysms. And still, we cannot go so deep into these numbers, but that's, I'm staying here because this is a really very important study. And that's the most important finding. The Rankine score of poor outcome, defined as 3 to 6, so larger than 2. I would consider an unruptured aneurysm, even a Rankine score of 2 is a poor outcome for the patient, but that's a matter of debate. But this is a very good and hard endpoint, and it's the same in surgery and endovascular treatment. So it's 2%. 2% in the best hands. But let's have a look at the individual patients. That's interesting. We have on the surgical side a complication, MRI score of 4 in a 10 millimeter patient. Size of the aneurysm 10 millimeter. Another complication, 14 millimeter PCOM. Patient died. There is one patient, and I wrote him, and he said this is a patient who died from a pulmonary complication, so it has nothing to do with the aneurysm. And on the endovascular side, we have a 15 millimeter ACOM, you have a 12 millimeter MCA, and you have a 9 millimeter PCOM with a poor outcome, leaving us to a complication rate in the small unruptured of 0. And this is kind of interesting. Just, of course, it's never 0, but still, in this very, interesting patient group of less than 7 millimeters, or maybe even 8 millimeters. There's not a single patient that has a complication in this randomized trial. I think that's an important information. So we can say that it's pretty much safe in good hands to operate or to endovascular treat a patient with a small unruptured aneurysm if we select them well. So now, and that's kind of I think the most tricky part, and I hope you have a cup of coffee. Just take a nip and now we need a little bit of math. Now I want to ask you, if you have a hypothetical model of 100 patients, 100 patients, and you have a group of patients, 100 patients, you treat by surgery and you treat by conservative management, and you assume it's a 5% risk of treatment complication, severe, and a 5% risk of rupture in the observed group. So at which point of time does the surgical group has an advantage in terms of the highest number of quality adjusted life year? That's the question. When starts the advantage, or when is there an advantage for the surgical group? And I asked these questions many times. I think it's still a different questions, although that's kind of how we make decisions. And that's just a hypothetical number. But most of us say, of course, after 5 years, because then it's when the curves are crossing. So this is 0, time 0, immediately after surgery. Let's say death for everything. Patient died, and now 5% after 5 years. Also, now the patients are losing more quality of life years with observation. And now let's think about a little bit more different. And for our calculation, of course, we use the exponential curve of the lifetime risk. But if you look at the 0.2, 0.5%, it's almost linear. So you can say it's linear, just to let you know that this is incorporated. And now think a little bit more different about it. You have 100 patients, and then you treat them. Next day, 5% have poor outcome. And now think about the 100 patient you counsel to do a conservative management. You send them home, and they are not having the next day the SAH. They collect over the life of the years of life, 1% in the first year, another percent in the second year, another percent in the third year, another, and so on. So basically, it's like this. So after 5 years, you are not having the same numbers of quality adjusted life years saved in the surgical group. No, it takes longer. It takes twice as long as we think it takes. And if we now consider in patients who had a rupture of the aneurysm, we have 30 to 50% good outcome. Still, some patients from the just rupture group still end up in a good outcome category, which makes it a little bit more difficult. And we have published this in the stroke, I think last month it came out. This is generally for all the unruptured or for all the preventive interventions with rather steady risk factor and a stable complication rate, where you have this situation. And then we can use a different statistics. I don't want to talk about this. Mean survival time, then you count them, and you see after 10 years you have a better result after surgery. So we have to keep this in mind. If we say 2% is the lowest complication rate in the world, and now I'm going beyond what Tim's study has shown, because I think they had some larger aneurysms. So let's say it's 2 to 6, and let's say it's 2%. And then I think it's a difficult table, but let's say 2% complication rate and 0.3% per year. It takes 20 years for the patient to get an advantage. And if we had more complication, it takes 40 years. So I think we underestimate this doubling in time until the patient gets a benefit from the treatment in terms of compared to waiting. So I think that's something we have to consider in the future. Treat only patients with major risk factor for rupture. What are the major risk factors for ruptures? Size, okay. We have decision maker and decision modifier, but decision maker size. It's growth, because growth triggers a higher number of ruptures. We have, and I'm a firm believer in changing configuration. If we just see a new bleb coming up, whatever, and it's clearly documented. And then, of course, we have the true familiar and we have the symptomatic unruptured. I think these are the decision makers. It doesn't mean that you have to treat the patient, but at least this part of the formula is now checked. Okay, that's, of course, the other ones are still to be taken into account. But these are the decision makers we have to keep in mind. Of course, there are decision modifiers. Posterior circulation, absolutely for smaller sizes. But, smoking, hypertension, alcohol, I don't think that is really a treatment or you can change something. And I would even say SAH from other aneurysms is not a decision maker, it's a decision modifier. How can I say this, and how can I think this is a reasonable strategy? There's one publication in Stroke from the crew where I was previously in Frankfurt. They included 384 patients with anterior circulation aneurysms, and they followed anterior circulation aneurysm, no SAH before. They followed everything that was below 7 millimeter and treated only the growing aneurysm. And in the remaining aneurysm patients, they observed an 0.2% rupture risk per year, which is exactly that is what's seen on faces. So there was no surprise, and it was pretty low and confirmed the model, basically. And then there's another study from a French group. They had 662 anterior circulation, even some posterior circulation, and even sizes up to from 7 to 10 millimeter. And they treated only unstable aneurysms, which is growing or changing configuration. And in their remaining patients not being treated and staying under observation, they had 0.1% per year rupture risk. And I think you agree we would not touch a patient with such a low risk of rupture unless there is really a reason, but not in general. So when we look at our database, we did basically the same. We are also following this strategy, and of course we are coming up, with almost the same number. Of course, there is a selection bias because we treat all growing. Of course, we treat everything that changes configuration. Of course, sometimes there a little bit of decision making outside this, but in general, it's following the rule that we don't touch the ones anterior circulation smaller than 7 millimeter. And it seems to be that's a good strategy in terms of deciding which patient needs treatment and not being surprised. Although the cases that had a rupture in our cohort had poor outcomes, so basically 5 of 6 died. The size was 4 millimeter, 3 millimeter, 3, 7, 8, and 9. So of course, yes, we had ACOM, P23 aneurysm, pericallosal, PCOM, so almost all the also distal sites. So, and I think, of course, we will never have a strategy where we have no complication or no rupture. So it's always a trade-off, but I think it gives us a little bit more information. What about the management of the risk factors? Yes, decision modifiers. What we can modify is physical activity, long sleep duration. That's summarized in some papers. I don't know what about the studies that really prove this, but smoking, hypertension, alcohol, I think that's recognized for decision modifier. And this is, of course, what we also suggest to our patients. So the advice, and when we talk to patients, this is an example. Don't worry, no treatment required. But change your lifestyle, stop smoking, visit your doctor every 3 months for blood pressure check, avoid coffee, wine, and beer, and whatever drink you enjoyed so far. Avoid sports, avoid coughing and sneezing and laughing, and remember your aneurysm when having sex. So basically, if you advise your patient like this, then you should treat the patient. So that's a kind of way we should not do. And it's quite clear that maintaining quality of life means, and we are talking about quality adjusted life years, and that's something we always come back to, means that the patient really doesn't change quality of life, it doesn't change his lifestyle. Otherwise, we have good ways, showing a very low complication rate when the patient undergoes the treatment. So if there is a situation where we make a decision despite the very low risk to treat the patient, then we can have a good faith, because we know the numbers also from Tim's study, and from in good hands. So in which patients do we not do any treatment or even no follow-up? And that's the extradural aneurysms. We stopped following carotid cave unless we have sometimes still not exactly, is this a cave or not? So I think everything that's larger than 3 millimeters is maybe not a cave aneurysm, and is going to be followed. Of course, small aneurysms and reduced quality of life. And then there is the ongoing discussion, can we stop following a patient? We do a yearly MRI, but only time of flight, no contrast enhancement, no, just for the size. And can we stop it after 5 to 10 years, or can we stop it when a patient reaches a certain age? We don't do any, over 80, of course, but still we can discuss it. We don't know. I will not talk about, drugs and risk. Everybody knows about the PROTECT-U study from NEMA, comparing blood pressure management and aspirin for preventing rupture and growth. And growth is equally used as a primary endpoint to rupture. And we are pretty much looking forward to his results. And I think that's the end. I know there was a lot of numbers and stuff and consideration, but we see these patients, and I'm deeply convinced we have to use numbers. We cannot just say, whoa, well, he had a previous SAH. Whoa. So we have to know numbers. Otherwise, we cannot make a decision. And the message that I want to give in this talk a little bit is that the risk of these small aneurysms that do not grow, not change in configuration, have no major risk factors, is very low, and we could go for a strategy just to observe these patients. Thanks a lot.
Thank you so much, Rabah, for this great presentation. Now the floor is open to questions.
Yeah, if I could just start, that was great. That's one of the more sort of lucid presentations I've seen of the numbers, and graphs it all out very nicely. I find that's really hard to convey to patients. The more I use numbers, the more I see their eyes glaze over. And in the end they say, well, what would you do? That's always the way you end up. And it's a question of how quickly you get there. But I want to just ask a couple of things sort of about the numbers and how you think about them. And the first was, I may have missed it in there in your beautiful graphic explanation of how much longer it takes to overcome the deficit of complications. To me, one of the big things is the discounted value of a complication up front at the beginning versus the years. There may be quality years, your MRS 2 or 4, but in my own way of thinking, my years in my 80s may not be as valuable as my years in my 60s.
Yeah. for this model, and the paper is really about thinking, and this is one factor of model, how we model. So of course the numbers may be different, whatever, but the model, we need to have a mathematical model at which time point the risks are basically taking over. And for this model, you can use the same, as long as you use exactly the same outcome on both sides, the model is valid. So you can say death, okay, then it's death in the graph. You can say poor outcome 4 to 6, then it's 4 to 6. Because we are not using different numbers, then it would not be possible to use this model. Yeah.
Right. But what I'm saying is a quality adjusted life year for a 60 in my 60s is not this. I think we value them mathematically equivalent, but they're not equivalent. Is that a fair statement, do you think?
Yes, that is true. And I think we wrote in the paper that there are some exceptions. You know, you may have a better quality of life with 65 compared to 50 if you are in some certain situations in your life. But I think the health economists, they say the life years that are coming the next, and they are higher valued than the ones in 20 years. So this would even more speak in favor of the conservative treatment, because then you save patients with a conservative treatment, you save their life still some years until they have their rupture, while on the other hand, taking them away from the surgical. But I wouldn't overestimate it too much. And, you know, ranking 2 would be ranking 2 on both sides. But yes, the life years to come in the next year, and so they're more valued, yes.
Yeah. And another sort of aspect of that is the psychology of the emotion, and we occasionally feel, not pressure, fairly often actually feel pressured to treat a patient who is more anxious.
Yeah.
And so there's the patient's anxiety and there's our own anxiety, and you know, in my training, I remember Dr. Wilson, you know, talking very much about the errors of commission versus the errors of inaction. And you know, and he definitely would punish you more for an error of inaction than for an error of
okay, that's
action.
different in Europe. Okay, but yeah, because then you are yeah, okay, I see. Well, yeah, I see your point, and still I'm, you know, always retreating into this area where I say it's just a model. Of course, if the patient puts something else into it, you decide differently. But if you have always the same factors and the patient doesn't care, whatever, we have to use a model to think, okay, he has a life expectancy of some of this and this years and so on. So we have to have the thinking and model behind. But these are exactly the decisions where I'm now confident enough, seeing the numbers from the randomized trial, that we can do very low numbers, even in a randomized trial. That is always a criticism. Okay, show me the numbers. Okay, you in your institution, you have a very low complication rate, but show me the numbers in a randomized trial. But now they are there. If you look inside, and you don't have to use the 2%, and don't take the 2%, go into the data, and then you see not a single one less than 8 millimeters had a complication of these patients. So we can treat the patients with confidence. And still, so now we can handle a situation when a patient has this psychological pressure and the patient wants to be treated. And very often they give it back to me. And I say, well, in my practice, we can say in some situations, we really recommend to do an intervention. In other situations, we tell you, no, we don't do, you know, whatever you want us to do. But there are a lot of situations where we need the patient itself telling us, are they afraid of the intervention and can live with the disease? Or are the patient, you know, afraid of the disease and they can quickly decide for intervention? So this psychology is the trigger in many cases. And that's how the patient comes in. But the patient has to have that. They say, how should I decide? And I say, it's completely the same risk. So you can decide what's best for you in your decision making, in your personality. And this is how they come in and can be actively involved in the decision making.
Yeah. The ISUIA, it always it amazes me the traction that has had and the persistence that it's had, and certainly it did wake us up to the risk being lower than we thought. But to me, that was always so fundamentally flawed in the selection. It was an irrecoverable in terms of the quality of that study. I don't know that could, you would even imagine publishing that today. So it's always interesting to me just how influential that has been for how flawed a study that it was.
Yeah, and it stays with the neurologists more than with us. So that's
yeah, and I find in my group here, I'm the most I'm the oldest, I'm the most senior one, and I'm the most conservative, and the numbers I think resonate more with me, and sometimes they look at me, I think, saying, why is he so conservative? And I don't like to admit it, but it's probably because I've hurt more people over the years, and as you recognize the consequences of that and start doing the math a little more carefully, you do become a little more circumspect and a little more thoughtful in how you counsel patients. But at the same time, the complication rates are a moving target too, and the numbers have gotten so low that you kind of understand the I don't want to say cavalier, but the intervention is not seen as momentous an occasion as they once were.
Yeah, I agree.
Yeah.
So I think that the solution is still there, that the risk is very low unless you have some risk factors. But if there is decision for the patient or the situation that the risk factors change, do it without thinking about it. So not without thinking, but maybe you can have trust to the results that we have.
Yeah. There's a question from the chat asking how you define a positive family history.
I think I would, to trigger treatment as a major decision factor, I would stay to the very conservative that you have to have 2 or more first-degree relatives. So 2 or more first.
I use that same criteria, and I always find the little voice in my head saying, "Well, we didn't look. We haven't looked at your family, so there's only one in your family, so it's not a family history. But we didn't look."
I agree, but
Majid, do you have other questions?
I just wanted to ask Dr. Rabe, what if you see in the follow-up images if there's any aneurysm wall enhancement, how would this affect your decision making?
Wall enhancement is popping up more and more as a potential factor. Wall enhancement doesn't mean that the patient will have a rupture. There's some studies showing that patient with no wall enhancement, they have never of them had growth or rupture, or very, very low. And if you may have a higher likelihood, but not triggering treatment. So I think growth is the first to come before rupture comes. But still, this is a difficult topic because it would require that you give, for every follow-up, you give gadolinium. And still the protocols they are not the same. So people are diagnosing wall enhancement somewhere, which is just an artifact, whatever. So I think it has imaging implementations and difficulties, and also maintaining this over the years to have it as a major decision factor just by giving gadolinium all the time. So that's, at least in my institution, they want to do this, and so we switched to the time of flight and stayed with configuration changes and with size changes.
So that was something I had hoped to clarify as well. So your follow-up protocol now is non-con, time of flight only, and
every year.
Every year.
Yeah.
I've got a geometric progression where once I get to 5-year interval, then I do only 5 years if it's been stable for 5. Again,
yeah, I think
it's voodoo.
We just need, I think, maybe we have to put together all the data then to see how many really grow after. But we saw, of course, growth after 5-6 years and so on. And And if you have a patient, you know, in the 50s and you wouldn't like to stop after make a 5-year pause in when he's, you know, 58 or so. But that's kind of individual decision making.
I find it hard to tell my 80-year-old patients that I don't want to look anymore.
I know.
They feel abandoned. Or maybe I
Unless
feel
you
like I'm
say,
abandoning them.
yeah, unless you say we have data supporting that at your age, the risk is now considerably longer or lower, whatever, but we need this data and we, yeah, hope to give some soon.
All right. Really enjoyed visiting with you this morning and enjoyed your presentation. I learned a lot, and it's really a long time since Phoenix, but good to see you.
Oh yeah, it's Cameron. Always
yeah.
good memories.
Yeah. So thanks so much for being here. Really
Thank
appreciate
you.
it, and all the best to you.
I really enjoyed. I really appreciate being invited. Thank you.
Thank you.
Bye bye now.
Thanks to all.